Hello and welcome to Dragon Bytes, the paediatric podcast aimed at paediatric trainees or anyone interested in child health. I'm Asim, one of the paediatric trainees here in Wales. We've got something exciting happening today. We've got a new host. Dr Thomas Cromarty is one of our paediatric trainees based here in Wales. He's been helping out with Dragon Bytes from the sidelines since the very beginning, but now he's joining us with hosting duties. Today he's going to be discussing the culture of microbiology with one of our microbiology consultants, Dr Gavin Forbes. Dr Forbes is also the lead for Paediatric Microbiology in the University Hospital of Wales, and together they're going to be discussing how and when to use blood cultures and urine cultures, and little tidbits that we should probably all know about them. Anyway, take it away, Tom.
Hi, I'm Tom. I'm a new Dragon Bytes host.
Hi, I'm Gavin Forbes. I'm one of the microbiology consultants in Cardiff, and I'm the microbiology lead for paediatrics.
Okay, so today I think we're going to cover the culture of microbiology.
Very good.
So hopefully, Gavin, we can start with actually just asking a bit about yourself and how you got into microbiology and how others who are interested in it might find out a bit more.
Yeah, sure. So as a bit of background, I'm 34. I've been a consultant for just over 2 years. I came to microbiology in a sort of fairly roundabout way. Did my medical school, qualified, did the beginning of my foundation year, didn't really enjoy it, felt like the job that I was doing wasn't particularly satisfying and doing all the out of hours was really painful. Briefly thought about quitting medicine, but couldn't really think of what else I wanted to do. So I spoke to my education supervisor and we looked at things that I enjoyed about my job and something that wouldn't mean I was in hospital for 13 hours at a time overnight. Came upon microbiology and did quite a lot of infection stuff. My first couple of foundation jobs were in orthopedics, so dealing with prosthetic joints, and diabetes. So I did lots of diabetic foot, and I found the infection stuff interesting.
Yeah.
So I applied for microbiology training straight after F2, which you used to be able to do back in the old days. Didn't get in, did a year as a trust grade in acute medicine in London, which was great, and exposed to all sorts of infection-related stuff that I didn't see as a foundation doctor in Devon. Got in the second time. At the time I joined microbiology, it was a 5-year run through, so SD1 to SD5, all at the end. And I came here to train. I've trained in Cardiff, consultant in Cardiff, and it's been great. I've been here just over 7 years now.
Okay.
For anyone wanting to join microbiology now, the training program is different. There's a different pathway into it. So now you have to have done your core medical competencies during CT1, CT2. Get your MRCP, and then you can go into the ST3 training program, which for the first 2 years is called combined infection training. So you do your ST3, ST4 in microbiology and infectious diseases, and you can then subspecialise from ST6 onwards, and the length of your higher specialist training depends on what you want to do. You can do just ID, you can do ID and micro, you can do just micro, but it's a slightly more onerous route into it now because the direction of travel for microbiology as a specialty is that we are more clinically focused. So in the old days, microbiologists would sit in their office in the laboratory and they would authorise stuff. You'd never see a microbiologist on the wall. But now the drive is to get microbiologists out and about, interacting with clinical teams, going to see patients. And so the training programme has changed to allow that to happen.
Okay, fantastic. So you obviously see adults and children, or
yeah.
And I suppose as a paediatrician, some of the times where you have clear differentiation between adults and paediatrics, and within microbiology, where do you see the main differences?
So it's difficult. I mean, most of our practice obviously is directed at adults. So that's what most people encounter during their training, and that's what most people will deal with as a consultant. I came into paediatric microbiology because I thought it would help me get a consultant job, if I'm completely honest about it. Tried to look for a niche where I could develop a service, found that I thought paediatrics here in Cardiff was underserved by microbiology, said I can do something about this. So we started new MDT, tried to get a bit more involved, building relationships with all the paediatric specialties. So I think that a lot of the differences people don't necessarily see because their contact with paediatric practice is relatively limited. From my point of view, I think it's about how you approach the child with infection that's very different to adults. Because obviously as paediatricians you all know that non-verbal children can't give you a history, and that signs in very small children might be very non-specific. You don't get that in adult medicine. So there's it's working out how to approach that child and what might look like over-investigation and over-treatment in adult microbiology really isn't in paediatric microbiology. and even then, once you've worked out what's going on with the child, there are so many differences in how you make the diagnosis, about your testing strategies, and about how you treat them, that actually, people always say in paediatrics, children aren't small adults, but it's very much true in infection, because then you can't just take adult strategies and scale them down. It really doesn't work.
Okay. Thanks. I think that's a good introduction. I think we'll just go to the main topic really, and I wanted to talk about specifically a couple of different investigations. One of them was blood cultures, and one of them is urine.
Okay.
So why don't we start with blood cultures?
Let's.
Is the way that blood cultures are performed the same everywhere?
Pretty much universally now, yeah. With the advent of automated monitoring techniques, pretty much everywhere does blood cultures the same.
So previously, I, and hopefully I speak for some other doctors as well, had thought that when you send the blood culture, the blood goes to the lab, it gets put on an agar plate, and then we see what happens and see what grows and what doesn't grow and what antibiotics work against it.
Yeah, so if you talk to some of the more senior biomedical scientists in the lab, they will tell you that that's how it used to work in the old days. The blood would come in, they'd plate it out onto a variety of plates, they'd go in the incubator, and they'd be checked every 24 hours to see if they grew, and things would be developed from there. That doesn't happen anymore because it's very easy to get contaminated. It's very workload intensive, the BMSs. So now you send us a blood culture bottle, we get it, we put it on a machine. At the bottom of the blood culture bottle is a little indicator, and what that measures is CO2 levels in the blood culture bottle. As the CO2 level rises, the indicator changes colour at the bottom of the bottle. The machine reads that, says this blood culture bottle has got something positive in it, flags it up to the BMSs, they pull it off and then start working on it.
Okay, so then it's only that group that's got the positive indicator that get that workup.
Yeah, so they get automated. We do occasionally see blood culture bottles ping positive that don't have anything in them. So we see it particularly in haematology patients who've got a very high white cell load, because they will metabolize, they'll produce CO2, and it will look like there are bacteria in there.
Okay.
But we plate it out and nothing ever grows and we never see anything. But that's few and far between. If it comes up positive, it's probably got bacteria.
Okay. And so then that process after that, you've got your positive indicator there, you then pop on to what now?
So they get pulled off the machine at regular intervals throughout the day, starting at about 8:30 in the morning, and the last ones come off at about 8 at night, I think. Some labs will go 24 hours, but not all labs are as resourced for that as others. Comes off the blood culture machine, and the BMS will start processing it. So the first thing they do is a gram stain, like the most basic of all microbiology tests. Put a bit of blood on a slide, stain it with the normal gram staining process, and have a look at it and see if they can see anything in there, whether we're seeing gram positives, gram negatives, if they're bacilli, if they're cocci, if they're yeasts, if they're, to try and get an idea of what's going on. The blood then some of the blood gets taken out and it gets plated onto a variety of agar plates, depending on the indications written on the clinical request form, and depending on what they've seen under the microscope. So we've got a set of standard plates that everything gets, and we might have some more specialist ones if we think they're indicated, we think they're likely to grow something relevant. They get incubated, they get read for the first time somewhere between 18 and 24 hours, and then about every 18 to 24 hours after that until they've grown something that we can work with.
And so you mentioned about clinical information. So me putting query sepsis isn't particularly helpful.
It doesn't tell me very much, because that's the reason you sent the blood cultures.
Yeah.
So it doesn't tell you anything about why you sent the blood cultures. So I know the child is presumably septic because you sent some blood cultures.
Yeah.
Further information is always helpful. So as much information as you can cram onto it. And if you've got no information, that's fine. There's nothing you can do about it.
Yeah.
But the more information you've got for us, the better the results you're likely to get.
In that case, I'll do better.
Cool.
Coming from being a foundation doctor, always sending an anaerobic bottle and an aerobic bottle.
Yeah. In
pediatrics, obviously, we're only sending one.
Yeah.
How does that work?
So actually, you're probably not missing very much by not sending an anaerobic bottle. There was a paper published a few years ago from a study that was done in Chicago, I think, where they took aerobic and anaerobic pair from pretty much an unselected bunch of kids that came in with infection, and actually the number of obligate anaerobes that you're missing by not taking an anaerobic bottle is very, very small, and you can risk stratify the patients that you think you need an anaerobic bottle on relatively easily. So essentially they're compromised hosts because they're immunocompromised from HIV or transplants or chemotherapy or whatever, or they've got something abdominal going on with them.
Okay.
So if you think, a surgical kid coming in with appendicitis or something, you might well take an anaerobic bottle because you might pick up a bacteroides or something. But actually in undifferentiated mass of children coming in with respiratory infections or urinary tract infections, you're not missing very much by not taking an anaerobic bottle.
Okay. So if we had those patients that we thought were particularly might use an anaerobic bottle, we would just go and get the one from the adult
just go
side?
and claim an adult set. They're exactly the same. It's got the same growth medium in, so
Okay.
you're not gonna lose any specific pathogens by doing that.
Lovely. The next issue that I wanted to bring up was volume of blood. One of the reports I get back is often that there was an insufficient sample, or the yield isn't very good. So just hopefully you can clear up.
So that would be nice. But actually, the evidence is not overly strong about blood volumes in blood cultures. We know that most blood cultures we get sent from paediatric and adult medicine are underfilled, and that therefore means that we're not sufficiently powered to detect bacteria. So we might miss a lot of blood cultures. There's a study done in the States in the mid-90s looking at blood culture volume, and they did a sort of very complicated setup of one culture with just one set of blood in, and they took a bigger sample and divided it into other volumes. And actually what it shows is that 3 mils of blood per blood culture bottle will significantly enhance your detection of pathogens in 24 hours. So a lot of people say 1 mil. There's a paper I read earlier we're talking about working it out based on child's body weight and therefore their circulating volume, and taking somewhere between 1.5 and 4% of circulating volume. Like, who's got time to sit and work that out when they're taking blood cultures from a presumably unwell child? So a mil is probably not enough. 3 mils probably our goal.
All right.
Per blood culture bottle. And obviously always when you're taking blood cultures, 2 sets of blood cultures, because that means that if we're detecting something in one blood culture that we're not entirely sure is significant or not, if we can detect it in 2, much more likely to be significant than...
Okay. I suppose what I'm thinking about, little babies that come in less than 3 months with a temperature, and I've got a tiny little 24 gauge cannula in.
And try and get 3 mils of blood out, that is not going to be particularly easy. Fine. I mean, there are always going to be circumstances where you can't get enough blood out, but more blood is always more better. Because it's going to increase your ability to detect bacteria.
Sure.
And there are some bacteremias that come with very high bacterial loads, and they're very easy to detect, but there are some that don't. If you've got an occult bacteremia in an unwell child, if you can detect that early, the outcomes of that child are going to be better.
Okay. One of the other common bits of feedback we get is that there are contaminants in the sample. Is that down to me not cleaning the skin properly, or
so not necessarily that, but yes, a lot of people will ask, have you contaminated in the laboratory? And that is virtually impossible. So the contaminants will happen at some point before they come to the laboratory, and with the best will in the world, you'll never be able to eliminate blood culture contamination. There are lots of steps you can do to reduce it, but you'll never be able to get rid of it entirely, just because it's a open biological system. Once the blood culture has had its blood put into it, it comes to us as a sealed system. Nothing else is going to get into it, because it's a self-sealing bug. So if you've got a contaminant from the blood culture, it's either because your skin prep wasn't great. We know that happens. That's why people get cannula site infections. Because the taker has mishandled the blood culture bottle as they've been doing it. They might have wiped the top and left it for 30 seconds for alcohol wipe to dry, and then accidentally touched it with their thumb when they were setting it up. Because children wriggle and they play, and it's difficult sometimes to get stuff out of them. We occasionally see what looks like oral flora contaminating blood culture bottles, and our assumption is that people have sneezed on them. If we do get contaminants, the vast majority, I would say, of our positive blood cultures are contaminants eventually. But it's just about good quality sort of venipuncture and taking those blood cultures in as an aseptic way as possible.
So my practice is to obviously clean and then wait for the 30 seconds. But what about the changing of the needle? Should we be changing the needle once we've taken the blood culture, changing the needle to make it a clean one to put it in, or was that overkill?
It's probably overkill, because you're going to the more steps you introduce, the
Yeah.
harder it is to keep everything clean.
Yeah.
I think so. If you've just got your needle in and you've got your vacutainer end on it, as long as you're not touching that and all it's doing is going into the blood culture bottle that you've cleaned and then taking it off and then going into another one, it's probably okay.
Okay. I'm thinking most of the blood that I take anyway is never with a vacutainer. It's always on a tiny little baby with a needle and a syringe, and I'm taking it from the back of the cannula sometimes.
Yeah.
And just aspirating as little blebs come out.
Yeah.
And I suppose that has a chance for that needle end to be touching the end of the plastic.
Yeah. I think, taking blood culture with needle and syringe is always difficult because aside from the sort of logistical challenges of getting blood out with a needle and a syringe out of a very small arm, you start to run the risk of needle sticks when you're sort of waving needles around and sticking them in tubes. So we don't advocate it, but occasionally there isn't any other choice. Yeah, and that's fine. If there's no other choice, I'd rather have a blood culture than not.
Sure. There are some clinical situations where I'm concerned that the child's unwell, it's most likely to be a virus, but there are some risk factors that are present. So I would do some bloods, I'd send off a full blood count looking for a white cell count and a CRP, and I'll take a blood culture at the same time because I don't want to prick the child more than once. And so I have the idea that I will wait for the inflammatory markers to come back, and if they're significantly raised, then I'll send the blood culture.
Okay.
Is that all right?
Can be. Yeah. So I think the first maxim is treat the patient, not the results.
Yeah.
So if you go to that child and your first approach is this child looks sick, they might have a bacterial infection, send a blood culture.
Yeah.
Because it might be that their white cell and CRP response is slow, getting a lag a bit, and then they've had some antibiotics, you've missed your chance to get a good quality blood culture. So if you're going to take one and your pre-test probability is such that you think you're probably going to give this child some antibacterials, and just send it.
Okay.
I mean, I can't tell you off the top of my head what it costs to do a blood culture, but it's not a vast amount. And given that we process 20,000+ blood cultures a year, the addition of one or two I don't think makes a great deal of difference. And if it turns out they have got a virus, then fine. If the result comes back negative, great. If it comes back positive, you can always go back and reassess and say, actually, maybe there is a bacterial infection or maybe this contaminant. But the more information you can get about that child, I think the better. So I don't think there's any reason to not send it unless it's really obvious that actually they don't have a bacterial infection at all.
Sure, sounds reasonable. Are there any other, before we move on to urine there, is there any other pearls you can think around blood cultures that we sometimes...
Yeah, so one of the most common calls that we get in microbiology is, has this blood culture result flagged yet?
Yes.
I've
never made that call.
No, and it happens less often than it used to. It used to happen more often when I was a junior. It happens less often now, which is good, and I like to think that's down to me. But obviously the clinician is concerned about this child and wants to know what the blood culture is doing because it's going to inform what their ongoing plan is. But the corollary to that is, when did you send the blood culture? Because it's all very well taking the blood culture. But if you then put it in a box on the ward and wait for the porters to come and get it, we're not going to get it for a long time. It's not going to go on the machine. Your 36 or 48 hour report isn't going to arrive until we put it on the machine, not necessarily from when it's been taken. Some colleagues in the lab looked at blood culture transport times a few years ago. And if you exclude the 3 biggest outliers from that set of data, the mean time from taking to arrival in lab is 10 hours.
Okay.
And I think it's important to get across to everybody really that's taking blood cultures that these are time critical samples. So you wouldn't leave a CSF lying around for 10 hours because you've taken it and you need to know what's going on in someone's CNS. But similarly, if you've got a septicemia, if you've got someone that's bacteriemically really sick, why leave the blood culture lying around on the ward for 10 hours? If you've got a sick child in front of you, you're taking the blood cultures. Find someone will take them to the lab for you, because they'll get on the machine. We're much more likely to get a rapid result. Even if we don't, you'll get your 36 or 48 hour negative in a more timely fashion because they're with the lab 5 minutes after you've taken them rather than 10 hours. So, they're time critical samples. They're from unwell children. Get them to the lab as soon as you can. Okay.
And in the lab, when it goes on into the machine, it's a heated system, is it, to try and make that
so
process happen?
Yeah, so it's incubated to about 37, 38 degrees, something like that. So it replicates body temperature. So you take them to the lab and they might sit in a box for a bit, but if they're sitting in a box for an hour or so, that's not the end of the world, because there's plenty of growth medium in there. The blood's still warm from wherever you've taken it out of. You will start to get things, but the sooner you can get them into a more hospital environment, like an incubator, the better.
Brilliant. In that case, we'll move on to talking about urine.
Cool.
Probably one of the most common things that is sent in paediatrics.
Just in general,
In general. And I know there's lots of contentions about when you should and shouldn't send it. If we've got a source that we think is present, then probably don't need to send it, and it's just adding to, cost as well as investigations that don't need to happen, and potential antibiotics from that. So what's your view on when we should and shouldn't be sending?
Okay. It's difficult. In adult medicine, there are lots of urines that shouldn't be sent, because there is a lack of understanding about what a UTI is and how to investigate for it. And I don't think that's as prevalent in paediatrics. And the nice guidance about assessment of fever under 5s is very clear about when you should and shouldn't send a urine. So if you can refer back to that, I think that's fine. I think if there are uncertainties about it, you've got to think about, again, what's your pretest probability of a UTI? Is this urine going to alter your management? And that was a bone of contention for a little while when I was a reg, and we would be woken up in the middle of the night by someone very well-meaning and saying, "Can I have this urine microscopy done urgently?" And that's fine, because that's what NICE says. It needs to be done in a timely fashion. I can't remember off the top of my head how quickly. But actually, you've got to think, is this test going to alter my management right now? And for a lot of urines, it's not in a very short sort of urgent space of time. So urines can be done routinely, and they get done, and then we've got a very good process for doing it in the laboratory, even though we process upwards of 100,000 urines a year. I think if you've got a child who is very unwell and you've got no obvious source, then send it, because it's a very easy sample to collect. You can do it non-invasively in most circumstances, and it might well give you an answer if you've got a 3-month-old who's septic and unwell and you don't know what's going on with them. If it's a UTI, great, it's easy to treat, it's easy to diagnose, problem solved. If you've got an older child and they can give you a good quality history, because that's really what UTI is about, it's about getting a good history and having a very specific set of signs and symptoms, then great, send it. If there's diagnostic uncertainty and you've got an unwell child, that's fine, but I think there are some urines that get sent that probably shouldn't.
Okay. And you mentioned about 3 months then, and I think again when you look at the NICE guidance, whether that antibiotic then is going to be IV or oral, and it seems, for me, when I've got a kind of a wellish looking child who's 3 months on this on that age, whether they were a week earlier, then they'd be coming in for IV antibiotics, and they're a week later and they're going to go home and have it orally. What's the current thinking about when we should be giving IV and why in those ones? So
I think you would give IV antibiotics on that basis to children that you thought had an upper tract infection, which obviously is going to be very difficult to diagnose, but if they're significantly unwell, the likelihood is that it's more likely to be upper than lower, so you probably give them IV antibiotics. If they can't take anything orally, so if they've got vomiting, which often comes with a UTI, then you give them something IV. If you've got a relatively well child who's sitting on the borderline, I think it's very difficult to prescribe exactly when you're going to give IVs or orals. I think if you've got sensible parents who know what to look for, if their child's getting more unwell, they're going to bring them back promptly, then it's probably okay to give them orals and some, look out for these red flags, give some safety netting advice. I think if you've got concerns about whether this is spreading, because obviously gram-negative sepsis is one of the biggest causes of deaths in neonates and infants, then I would keep them, and you can always send them home 24 hours later when you've got something out the urine. It was a UTI. So you could hedge your bets a little bit, but it's very difficult to be exact about who to give IVs to and not.
And I know 3 months, sometimes they're very, especially boys, can be easy to catch a wee. Otherwise, the rest of the time, it's a bit of a nightmare. And sometimes, unfortunately, parents will be waiting for 4 hours and then miss it.
They miss the one time,
and obviously, bagged urines,
no use.
Absolutely terrible. But if you've got a negative bagged urine,
it's difficult to know. A negative, I don't think, tells you very much, because then you don't know, how long has that urine been sitting around, how well has it been caught. The likelihood is that it's going to be full of contaminants, and you're probably getting a positive, and it's going to be full of mixed growth, and you're no closer to generating an answer. If you've got a negative, then you've got to go back to your pre-test probability and say, how likely do I think this is to be a UTI? Because actually, if you're waiting around and you catch a bag urine and doesn't grow anything, but the child's really snuffly and coryzal, they say, actually, it probably was never a UTI, and I don't really feel very bad about this test result. But if you've got no other way to explain it, then you might try again and work a bit harder to get a good quality sample.
I suppose that's one of the things that I find like one of my bugbears is when they've got symptoms, and sometimes you still hear, I better send it anyway just to check. Is there, having concomitant infections, is that likely?
It's not unlikely. So people talk about Occam's razor and about only having one diagnosis at a time, and then there's Hickham's dictum, which says patients can have as many diseases as they damn well please. So people do come in with it, and particularly in children, at this time of the year, every other child has got an upper respiratory tract infection. It's just facts of life, isn't it? So yes, they could develop a UTI at the same time, and you don't want to focus on one thing to the detriment of the other. So I think if you've got a reasonable suspicion and you're not just sending it as a matter of course, we better send it just in case, then that's fine. But the routine sending of UTIs with a low sort of diagnostic probability is probably not very helpful. Okay.
And just for understanding the process, what happens to the samples when it gets down to the lab?
So they appear with us in our urine lab. So we've got a whole room set aside for processing urines. They get graded almost about how sort of it's a bit like grading maple syrup. It's about grading like how dense they are, about how thick they are, about what their colour is, because we have to dilute them out to a sort of a standard to make sure they get processed appropriately. They then go on our automated analyzer. So in the bad old days, every urine would get put onto a glass slide, and the cell count would be done manually by a vast array of BMSs. These days, the urine goes into a tube and goes on our automated analyzer, which uses a sort of photo recognition system. So it knows that it's looking, we'll sample a certain amount of urine from each sample, and we'll take photos, and then we'll process that against its database to look for white cells and red cells and casts and things like that. We will take the results off that machine, and anything that's flagged and says, yes, this meets our culture criteria, which are all described in our standard operating procedures, will then go on and get cultured. There are lots of other things that get cultured irrelevant of what the analyzer says. So from immunosuppressed kids, for example, so if we know the samples come from paediatric oncology, they'll get cultured anyway, because we can't rely on their white cell response to indicate to us whether we culture it or not. Gets placed out onto our UTI media, which is chromogenic. So it has various nutrients and things in it, and also indicator chemicals, so that as bacteria metabolize things differently, they produce different waste products, reacts with the indicator chemicals, and goes a different colour. So E. coli's will come up as a different colour to Klebsiellis, for instance. So we can already start, without having done very much work, to identify which bacteria there are. Stuff that comes up positive and looks like it's useful will then go on and get sensitivities. So all of your sort of urine gram negatives, your E. coli's, your Klebsiellis, your Proteases will go on and get sensitivities done. There are some things that will grow in urine that actually aren't very useful. So if you've got lots and lots of epithelial cells in it, which suggests it wasn't a true midstream sample, and you grow some coagulated stats, that's probably just external urethral contamination, and we don't really do very much work with that because it's not very helpful. So we go on, and then the sensitivities get done, and we will issue a set of sensitivities probably about 48 hours after the lab gets the urine. Given the sort of massive workload of urines, it's sometimes a bit slower than that, but as quickly as we can, we'll get a set of sensitivities out.
Sure. And where I've worked, most places they have two bottles, either the kind of like universal bottle with a white top, or some samples with boric acid in it. And when should we using both?
So we should be using boric acid for everything, for all of our urines. The cell count is much more likely to be stable with boric acid, and you're likely to get a better bacterial growth yield just with boric acid adding a bit more. So just neutralises the pH. It means that everything's more likely to survive that little bit longer. So if you've got a urine and it sits in the fridge for a few hours or whatever, you're likely to get a better yield off it than just in plain UC.
Is there anything else you think is useful to mention about urine cultures. I mean, what about the white cell count? And I haven't kind of worked in children's sesame unit in a while, but that always seemed to be, when is it a significant number?
Yeah, I think it's difficult with white cells because there are so many things that will give you white cells in your urine, and it might be that you've got overspill from the blood. If you've got a very high circulating white cell count, you get a high urinary white cell count, and it doesn't really tell you very much. People always think about 100 as a reasonable cutoff, but actually the reproducibility of cell counts in urine samples is relatively low, so it's difficult to describe that exactly. We changed our urine testing SOP 5 years ago, maybe a bit more than that. We stopped giving out exact cell counts, and there was great uproar from a variety of clinicians going, I need to know the cell count so I can act on it. Yeah. And we said, actually, well, the cell count's not very reliable, so if we test that urine 5 minutes later, the cell count might be wildly different. Yeah. So we give a vague indication of what the cell count probably is. I think you can look at the cell count and make some conclusions from it. So if there's lots of white cells in it and not very many reds and no epithelial cells, and you've grown something, probably does represent a UTI, or at least a bacteriuria that's floating around in the bladder. Whether it's relevant or not depends on your signs and symptoms. We talk about looking at weight of bacterial growth, so greater than 10 to the 8 is probably relevant. A bit less than that might be relevant, depends on the clinical situation. But looking at it just on the cell count, I think it's very difficult to judge that in isolation.
Okay. Any other pearls?
For urines?
Urine pearls?
No, I think it's just making sure that if you're taking a urine, you think about what it's going to do for the patient. It's like, are we going to act on it? If you're going to start dipping urines, it's about making sure you know how to interpret a urine dipstick. So I'm not very excited about seeing a urine that's got a bit of protein and a bit of blood in it. The renal physicians might be. Yeah. But as an infection doctor, I'm not particularly excited about that. If you've got lots of leukocytes, you've got lots of nitrites, that's fine. Don't be fooled by the nitrites. There are some organisms that don't produce them, and you still get a UTI with them. So it's not always reliable. You can't just say it's nitrite negative, it's not a UTI, which you shouldn't be saying anyway, because you should be judging it based on your signs and symptoms. There are plenty of resources about diagnosing and managing UTIs available, so it's worth having a look at it.
Okay. And empirical antibiotics wise, I know where we are, we've got just local guidelines.
Yeah. So it's difficult to judge, particularly with urinary isolates. The resistance rates and susceptibility patterns are so varied. Public Health Wales puts out essentially an overview of it every year, and they're sort of urinary E. coli's, and the E. coli's then go on to cause bloodstreams. And you look at the resistance patterns, and you can't apply what happens in one area of Wales to another, and that holds true across the whole of the UK. It just isn't generalisable. So always look at your local guidelines, because they have been written for your local sensitivity patterns.
Lovely. Well, thanks very much for chatting about both those investigations. Have you got any other tips generally for trainees that would help you guys in the work that you do?
Yeah, so we try to be as approachable as we can. Okay. So, from working in Cardiff, there are always microbiologists available. So the microbiology regs are available 9 till 5 most days. There is someone on call 24 hours, whether it's one of the trainees or one of the consultants. We're here at the weekend. If you've got questions, don't hesitate to phone us. That's fine. If your question's about what to prescribe, then there's guidance available. So here in Cardiff, it's MicroGuide. You can get the app, you can download the guideline, tells you all about what to do. If you've then got questions, that's fine, give us a ring. If you're going to phone us, the same as if you're going to phone any other specialty for advice, please anticipate what we're going to ask you and have the answers to hand. I learned that very quickly as an F1 after a series of severe tellings off
dressing
from
down.
Consultants. Be in front of a computer, have the bloods open, have the notes to hand, have the drug chart to hand. Know what's going on. It's going to help you, it's going to help us. Please don't phone us and ask whether your blood culture is ready or not. If it's ready, if it's positive, we'll have phoned you. If it's not, you'll get an automated response. But if you've got questions, we try to be approachable.
Lovely.
Please give us a ring.
Brilliant. Well, hopefully on some podcasts in the future, we'll be able to talk about antibiotic stewardship, going into a bit more about kind of antibiotic groups and their modes of action. As well as looking at hopefully at kind of specific conditions, kind of sore throats, things that are really common that we sometimes run into some
Yeah,
problems with.
that's fine. Happy to take questions about it.
Yeah. Well, thank you very much.
Cool, thank you.
See you later.
Thanks, bye.
Bye.
Another fantastic podcast there for us. It's really great having a new presenter here, and we're looking forward to hearing more from both Tom and from Gavin Forbes in the future. Just to summarise a few really interesting tidbits I found from there, it's worth noting that BMS, which Gavin Forbes was talking about earlier, refers to a biomedical scientist. In terms of the amount of blood, that's pretty hard to determine. As much as we can get seems to be the general guideline. Urine bags are pretty much worthless, so it's probably best not to use them because it's just going to be full of contaminants anyway. Sometimes it is worth sending a urine with kids who have upper respiratory tract infections because, well, kids always seem to have upper respiratory tract infections and it doesn't necessarily entirely rule out a urine infection. However, sending urine samples just in case isn't advised. And finally, it's important to follow local guidelines, largely because the resistance to antibiotics seems to vary region from region, county to county, and country to country, so you might as well do what they're doing locally in your hospital. You can find a worksheet for this podcast on our website, www.dragonbytespodcast.com. Next week, Stacey Harris will be having a chat with Leona Walsh, the Performance Unit Manager for the Professional Support Unit. Anyway, that's all for this week. Thank you for listening to Dragon Bytes.